Ladies and gentlemen, good morning everyone. I'd like to welcome and express my gratitude to all the viewers. I am Dr. Se-ung Im, a moderator of Osstem meeting online today. It's my pleasure and honor to share a live transmission of one of Osstem meeting online series today. Osstem meeting is appreciated as one of the most valuable academic symposium in the world. It has been expanding to online transmission successfully as well. The viewers of series of live Osstem meeting online have reached over 100,000 people from over 60 countries since it launched in April 2020. All Osstem implant members appreciate for your interest in joining us. I believe the sessions ready today are also very helpful and informative to you. The live transmission of runs for about 2 hours. You can join it with leaving your questions in live chat sessions. Today's topic is the first session is against COVID-19, Korea's struggle in dentistry. It features experience of Korean dentists and guideline to treat patients at dental clinic in pandemic states of COVID-19. I'd like to welcome Professor Chang-joo, who speaks for this topic.
Hello, dear colleagues and friends. I'm Professor Park. Today, I'd like to talk about against COVID-19, a novel coronavirus disease 2019, Korea's struggle in dentistry. COVID-19 has truly changed a lot of things around us. Our family, our clinic, our society, and our country. It is COVID-19 that makes us meet here and now. Korea, the homeland of Osstem, is a very small, populated, and outgoing country located in East Asia, closely interconnected with other countries. As you know, we had a very hard time because of a lot of COVID-19 cases and deaths, particularly in February and March 2020. But now, everything looks well controlled and stabilized. We are ready to get back to normal. By today's lecture, I'd like to share and introduce what we know about COVID-19, what we do against COVID-19, Korea's struggle against COVID-19, and what we don't know about COVID-19 with you, and conclude a brief conclusion in the end. Disclaimer. This lecture does not represent the views of Korea Centers for Disease Control and Prevention, KCDC, Korean Dental Association, KDA, and Osstem Hyosin. COVID-19 virus is quite new virus, and there have been few guidelines and literature. Considering our patient safety, our dental guideline against COVID-19 is principally set up in accordance with the guidelines of World Health Organization, WHO, U.S. Center for Disease Control and Prevention, CDC, and American Dental Association, ADA, and modified in close consultation with the Infection Control Committee, Hanyang University Hospital, HUH. My dental clinic, Hanyang University Hospital Dental Clinic, or HUH Dental Clinic, is a hospital-based dental practice located in Seoul. We have 20 dental units and 2 operation rooms. We are 7 specialists in 5 dental specialties: OMS, perio, ortho, endo, and protho. 5 residents, 7 hygienists, 1 nurse, and 1 radiological technician and 2 lab technicians. I'd like to show you what we know about COVID-19. COVID-19 is the infectious disease caused by the most recently discovered coronavirus, SARS-CoV-2, in Wuhan, China on December 2019, and now a pandemic globally affecting. Its incubating period is 4 to 5 days, maximum 14 days. This is why the isolation period is set to be 14 days after the exposure to COVID-19. Its mortality rate is lower than 1%. Its basic reproduction number is estimated to be 3.2, meaning the expected number of cases directly generated by 1 case in a population. So if 1 person develops the infection, he passes it on to 3.2. Mortality of COVID-19 is lower, and the incidence of COVID-19 is higher than other coronavirus infections. It is reported to be less fatal in children and pregnant women. But recent report that a rare but fatal post-inflammatory syndrome, particularly related with children, for your information. COVID-19 is transmitted by airborne aerosol, droplet, and direct and indirect contact from the infected person's cough, sneeze, and so on. Large droplets over 5 micrometer travel in 1 meter. But droplet nuclei or aerosols below 5 micrometer travel over 1 millimeter. Triad symptom of COVID-19 is fever, dry cough, shortness of breath, but sore throat, tiredness, headache, and loss of taste and smell are also manifested. Frequently, it is very hard to distinguish it from common cold or flu by symptoms. Globally, WHO COVID-19 dashboard as of May 17, 2020 shows that there have been over 4 million confirmed and 300,000 deaths. Concerning disease process, most people recover from the disease without needing hospital treatment, but about 20% of the COVID-19 patients become seriously ill with difficult breathing and need hospitalization. Known risk factors of COVID-19 are people aged 65 years old and older, people who live in a nursing home or long-term care facility, people with heart, lung, and kidney disease, and people with diabetes and severe obesity. Many dentists are greatly interested in tests for COVID-19, I know. Generally, there are 2 types of tests for COVID-19. The first one is viral tests to detect the viral RNA by real-time PCR, or to detect if you have a current active infection. Viral test is more reliable but takes more time because it can take several days to be sent and get results back from the labs. But viral tests are market leaders. The second test for COVID-19 is antibody tests to detect the immunoglobulin against COVID-19 or to detect the immune response from COVID-19 exposure. It is less reliable because it is known that 1 to 3 weeks are taken till antibody production, but quicker. Now it is time to introduce what we do against COVID-19. In the early period of COVID-19, we experienced complete shutdown of hospitals because of asymptomatic or pre-symptomatic COVID-19 patients' visit. Strict separation and patient movement control among known, suspected, and COVID-19 free patients should be required. This is our hospital. The ordinary patients enter and use the hospital through the main gate. But known or suspected COVID-19 patients, they should be sent to an independent COVID-19 screening center. It is located outside or out of the hospital for further testing and treatment. They should be strictly divided to prevent total shutdown of the healthcare facilities. This is the first dental treatment scenario for patients with known or suspected COVID-19. All dental treatments should be delayed, and only emergency dental treatments such as bleeding control and facial trauma treatment should be carried out. This is my patient. She had leukemia and she had frequent gum bleeding. She was infected after visiting China and isolated and transferred to our hospital for persistent gum bleeding. Her treatment or bleeding control was performed in negative pressure isolation room under level D protection. Level D protection requires personal protective equipment looking like a space suits. And it needs strict procedure of donning and doffing. They must be followed. Access should be controlled and limited to the hospital. Only for patients without fever or respiratory symptoms. They are also requested to fill out the screening form focusing on recent symptoms associated with COVID-19 and recent travel history to the regions affected by COVID-19. At the main gate or controlled access point, the patients have got the first fever check. If the patients have fever, all symptoms or travel history to the region affected by COVID-19, they should be sent again to the independent screening center for COVID-19 testing. the dental office reception, the second patient screening, focusing on dental problems, and second fever check are carried out. Of course, all healthcare workers should have the fever check when they are in and out of the dental office. Korea is a very centralized country. If a patient has a history visiting the regions affected by COVID-19, this information is directly notified and shared to the healthcare workers by an alerting pop-up after patient registration. At the dental office reception, we comply CDC's standard precautions. Pop-up window to show the history of patient visiting to the region, like this. For receptionists and supporting staffs, personal protective equipment, PPE. They need nursing cap, goggles, face shield, and 95 respirator, non-sterile exam gloves, disposable apron with sleeves, and shoe covers. Of course, they tie the hair and avoid wearing earrings, rings, watches, and necklaces. In a lower COVID-19 alert level, the PPE for these steps are goggles, face shield, dental mask, and non-sterile exam gloves. They are okay. Transmission routes, particularly in a dental practice, are airborne by COVID-19. Patients coughing and sneezing, droplets and aerosols, which are generated by dental practices. Contacts and surfaces, direct or indirect. At the reception or before starting any dental procedure, source protection by the patient's own mask or respirator is very important. Like social distancing, dental unit distancing is also important. If dental units are separated, they are okay. If dental units are screened or blocked to each other, they are okay too. If dental units are not separated, please keep a distance of 2 meters of effective radius of aerosol generated in a dental procedure between dental units. And just consider skip using of dental unit in the middle. As for N95, or N95 equivalent, we have KF94, Korea Filter 94 respirator. Wear it for any dental procedure. Choose the right size and throw it away if it is wet or contaminated. About the reuse or sterilization of mask or respirator, please visit the manufacturer's homepage. Perform a user seal or fit check. That's the key. Cup both hands over the respirator and exhale or inhale gently. If air leaks around the nose, readjust nose pads for better fit. If the air leaks around a respirator margin, please readjust the position of strap or adjust respirator margin or edge for snugly fitting. The importance of hand wash cannot be overestimated. For any dental procedure, wash your hands for 20 to 30 seconds. 20 to 30 seconds. And gloving. Hand wash and gloving for each patient for any dental procedure. It was CDC's guideline when visually dirty, visually soiled with blood or saliva, or after using the toilet, wash your hands. If not, alcohol-based hand sanitizer was okay, but according to our guideline, wash your hands with soap for 20 to 30 seconds for each patient for any dental procedure. This is the second dental treatment scenario. Non-aerosol generating dental procedures. Dental unit distancing is stressed, such as caries, perio, and orthodontic treatments. Contact and droplet precautions. CDC's contact and droplet precautions should be complied with. Patients should be protected by nursing cap, goggles, disposable bib apron, and sterilized instruments. PPE for contact droplet precautions, or the second dental treatment scenario. Practitioners and first assistant need nursing cap, goggles, face shield, N95 or KF94 respirator, sterilized surgical gloves, disposable surgical gown, and shoe cover. You know that COVID-19 virus can survive on the surface for quite a long time. 2 days on a cloth. For contact or droplet precautions, place a barrier or protecting PVC film or cover for each patient on the dental unit, 3-way syringe, and a headrest. And they should be changed before starting any dental procedure. This is the third dental treatment scenario, is aerosol generating dental procedures. Dental unit distancing is also stressed, and airborne precautions, the highest level of precautions, should be complied with. Patients should be protected by nursing cap, goggles, disposable bib apron, and sterilized instruments. PPE for airborne precautions, practitioner and the first assistant need nursing cap, goggles, face shield, N95 respirator, sterilized surgical gloves, disposable surgical gown, and shoe covers. The second assistant or circulating should have the same PPE for airborne precautions. To minimize the aerosol, by using manual devices, rubber dam, cotton or gauze to dry, high vacuum suction system, and additional saliva ejector. Avoid using the spray function of the 3-way syringe by pressing 2 triggers simultaneously. Four-handed dentistry is essential. For surface sanitizing, wipe off twice by 50% benzalkonium chloride wipes on the surfaces. Spotlight handles, dental units, and chairs, equipment, and 3-way syringe. The most important thing is to have grace period, at least 30 minutes, till the complete drying or disinfectant evaporation. Handpiece sterilization is definitely necessary. When a dentist stops the handpiece by releasing the rheostat, the turbine continues to rotate for a second or longer because it comes to a complete stop. This minor rotation causes a suction force around the handpiece, and it is called as oral fluid retraction or suckback. Regardless of whether anti-retraction valves are equipped in your handpieces or not, Handpieces should be sterilized for each patient before using. At the beginning, end of each workday, dental unit lines and devices should be purged with air or flushed with water for at least 3 minutes prior to attaching handpieces, scalers, air water syringe tips, or other devices. Flush between each patient for at least 30 seconds. For restorative materials, disinfection of impression body and lab products, deep impression body in 0.1% benzalkonium chloride solution for 1 minute. In ultrasonic cleaning of lab products, deep in disinfectant, and cleaning by running water, and packaging. I know that there are some controversies about this disinfectant selection and treatment time. But 1 minute, considering the deformation of the material and potential harms to the patients, 1 minute in 0.1% benzalkonium chloride solution seems reasonable. This is fourth dental treatment scenario. Implant surgery in an operation room. Airborne precautions should be complied with. And we did not restrict any case for implant surgery. Invasive and complicated implant surgery, such as sinus lifting or drilling and implant placement, even in a hard bone, no case restrictions. They were performed in this guideline. Patients should be protected by disposable surgical drapes and by sterilized instruments. Sterilized instruments can help the patients from cross-infection. PPE for airborne precautions. Surgeon, first assistant, and second assistant, they need nursing cap, goggles, face shield, N95 respirator, sterilized surgical gloves, disposable surgical gown, and shoe covers. The second assistant needs these PPE too. For patient preparation, pre-procedural mouth rinse by 2% povidone iodide. Mouth rinse by 0.12% chlorhexidine digluconate are shown to be less effective for COVID-19 virus. Patients are covered by nursing cap, and goggles. Extraoral disinfection by povidone iodine. And surgical drape. Do you think it's too much preparation? But please consider, we are in the midst of COVID-19 pandemic. Yes, I definitely know that implant surgery is done in a dirty mouth. Complete sterilization is not usually required, and it is sometimes impossible to obtain. Not too much preparation. Patient's safety or our safety is our priority. After the implant surgery, remove sharps and contaminated waste. As we do in air, water, tubing, and lines in airborne precautions, saline flush the water line in implant mortar for 30 seconds. And discard the used drapes. The instruments should be dipped in enzyme solution and chlorine detergent. Mechanical cleaning of instruments should be done. And rubbing, sterilization, autoclaving, and storage is the procedural sequence. This is the interim report of our guideline. By obeying our dental guideline, the number of outpatient visits and implant surgeries dropped only at February, when Korea hit the peak of COVID-19 outbreak. As time passed to March and April, more visits and implant surgeries compared to 2019s have been accomplished in our dental clinic. I guess that this increase could be explained by patients thinking that the bigger dental clinic is, the safer their dental treatment will be. And no transmission of COVID-19 has been reported through our dental clinic up to present, because we set up and adhere to our own dental guideline. Now, I'd like to share the experience about our struggle against COVID-19 with you. Korea is in geographic and cultural vicinity with China. We had very painful experience of MERS 2015, but it was a good chance to innovate Korea's command tower for disease control and prevention. As of March 5, 2020, WHO reported that Korea has had about 324,000 tests and found about 11,000 confirmed cases. These overwhelming outnumbered tests helped us contact trace or confirmed cases and perform the preventive measures immediately. Google COVID-19 statistics show that there is a trend of worldwide increase of new cases. However, Since April, Korea's new cases dramatically dropped, and there have been very small new confirmed cases. We are using monitoring apps by use of digital technology and big data to trace the confirmed patient's whereabouts. And for self-symptom reports of the suspected patient to health authorities during isolation. Our extensive testing can be accomplished by creative drive-in testing facilities to run diagnostic tests, nasopharyngeal swab without close contact. And we even held parliamentary elections amid COVID-19. No second wave of COVID-19 could be obtained by healthcare workers' sacrifice and civic cooperation. Osstem, HIOS and AIC postponed the 2020 Osstem World Meeting in Turkey, replaced by online lectures and real-time communications by then all. But I'm very happy to announce to you reopening of the offline real seminars, face-to-face seminars on May 2, 2020. Every participant's wearing mask or respirator, and various PPEs are ready for the participants and the lecturer. But still, we have a lot of things we don't know about COVID-19. There have been no licensed therapeutic drugs for COVID-19. Chloroquine for malaria, lopinavir or ritonavir for HIV, and particularly remdesivir for Ebola are being tested. There are preventive vaccines for COVID-19. Immunity to the virus will last forever or for a short time. And COVID-19 will be changed from pandemic to endemic. We don't know. And as for our dental guideline, currently no data enough to assess the reliability and effectiveness of our dental guideline against COVID-19. This is the summary of my lecture. COVID-19 will definitely come to an end. Definitely. Always consider asymptomatic or pre-symptomatic COVID-19 patients over 30%. Protect yourself, and value of strict infection control and prevention cannot be overemphasized in our field. You think we went too far? We did too much? Please remember, our safety and our patient safety are our top priority. And please modify our guideline depending on your own country's and clinic's unique situation. I know that this lecture about COVID-19 in a dental setting is requested by Osstem, India.
Hi, Professor Park. Oh, thank you very much for your wonderful lectures. I believe this presentation is very helpful to the doctors in dentistry. I appreciate for it. I'm getting different feelings seeing you online Osstem meeting. How about, do you feel it?
Before saying my feeling about that, I'd like to express my gratitude and my loving to Osstem India because of the abrupt stop of my lecture. And at the near end of my presentation, the COVID-19 outbreak has changed a lot of things around us, our job, our society, and our nation. I'm very sorry to lose the opportunity of Osstem World Meeting, to meet Osstem hires and users and share our knowledge about implantology. But because of there are online meeting like this and real-time communication, I think this COVID-19 may be a blessing in disguise. Our technique and our knowledge, including our patient safety, can be improved by this kind of online lecture and real-time communication. Thank you very much for giving this opportunity to me, Professor Kim.
Yes. COVID-19 has been resulting in many changes and challenges. Now, we move to Q&A session about COVID-19. There are many questions while your presentations. Let's look into that. Let me see. This one is, there are so many air purifier now. So do you have some advice for HEPA filters can work the filter the COVID-19?
It's a very good question. HEPA filters are known to be very effective for the particle size around 0.3 micrometer. But the size of coronavirus, including COVID-19 virus, ranged from 0.06 to 0.2 micrometer. But don't worry. Working by electrostatic forces, HEPA filter can capture the coronavirus. But WHO and CDC strongly recommends positive ventilation, not only filtered air. Strong and positive ventilation of the air in the dental setting must be considered before keeping the HEPA filter used for air purification.
Thank you. You mean the positive air ventilation is more important?
Yes, definitely.
Yes. And the next is, as you know, in some dental clinic has sanitation as using the UV light. Do you think the UV light kill the COVID-19?
Professor Kim, you know that UV light can be divided into UVA, UVB, and UVC by its wavelength. Particularly, UVC is widely used for disinfection. Yes, UV light can kill the COVID-19, but the sterilization of UV radiation depends on surface texture and surface configuration so much. So do not solely rely on the UV radiation. And please remember, UV is very harmful. Particularly UVC is very harmful to your body, skin, and your eyes. Do not use UVC for your hands and body sterilization.
Yeah, thank you very much.
You're welcome.
And maybe the last question. Do you think that which is the most reliable method for COVID-19 surface disinfection in dental settings, such as the fumigation or spray or wipe off? Which one is the best?
There are a lot of settings of surface disinfection: fumigation, spray, or wiping. But KCDC, Korean Centers for Disease Control and Prevention, they announced the guideline: use of wiping out for surface disinfection. Fumigation is so widespread, and spray can generate another aerosol, or can be very harmful to your body. So wiping out is the best method surface disinfection, particularly in indoor setting or dental setting. Fumigation, spray, wiping out, but wiping out or wiping off for surface disinfection is considered the best way for dental setting. And you know, there are a lot of variations of surface disinfectants, such as Clorox or sodium hypochlorite or something like that. And the recommended lists of products, I found they are different according to the countries. Some countries recommend something, but other countries do not recommend that surface detergent. So please check up or consult to find out the most proper surface disinfectant for your home and particularly for your clinic.
Yes, you mean as you know, the direct wipe off is very important.
Definitely.
I see. And I think that we don't have enough time, so I am so sorry. And now I believe that this Q&A session and with your wonderful lecture may be very helpful and inform the dentist who concern the COVID-19 infections. And as you know, recently we are very interesting about as you know, you mentioned the air purifier, and sometimes the air purifier is the spreading the aerosols. So you mean the positive the air pressure, the ventilation.
Definitely. CDC and WHO recommend the best way to get rid of COVID-19 is positive ventilation. Not only depend on air purifier. Even any HEPA filter with higher requirements or higher ability to filter, they cannot prevent COVID-19 for quite a long time. And you must remember that a lot of droplets and aerosols, they landed even on the surfaces, not only in the air. The aerosols or droplets in the air can be purified by air purifier or HEPA filter, but droplets or aerosol or other bigger drops containing COVID-19, they landed on the surface and they only can be get rid of by wiping out or wiping off. Do not solely dependent on HEPA filter or air purifier. Please.
I see. And maybe recently there are many concerns about the spread of the COVID-19. Usually we have in the hospital, usually the negative pressure, the ward or negative pressure room is very important. What do you think about that?
I'm not sure, but in Korea, most operation rooms, particularly operation rooms, they are designed as positive pressure rooms to prevent the input of bacteria or viruses during the operation. Negative pressure isolation room is quite limited, even in well-prepared country such as Korea. And sometimes they are fully occupied. The COVID-19 patients should be sent to other places. So, negative pressure isolation room must be prepared in your country, but a little bit limited. Always consider when sending the patients to the medical facilities.
Yeah, thank you very much, Professor Park.
My pleasure.
And the wonderful lectures, and this Q&A session is very helpful and informative to the dentist. Yeah, thank you very much for here.
Appreciate it. Thank you.
Now we are moving to next session. The topic is internal sinus lifting using casket and simultaneous transmucosal vertical augmentation. Let me introduce Dr. Se-ung Im.
Hello everyone, I'm Dr. Im, the director of the Wise Dental Hospital. My today's topic is internal sinus lifting use casket and then simultaneous transmucosal vertical augmentation. Now we are suffering from COVID-19, And now in Korea situation is calmed down, but I believe we can overcome this coronavirus and we can go back to our normal lives. This kind of complex defect, if we meet this kind of defect, very challenging to us because we need the sinus and vertical augmentation simultaneously. And I choose this topic because there are so many things to be discussed, and then I will briefly introduce these cases and then elaborate it, important concept in each step. As you can see, there are serious bone defect in the upper molar area, and I decide to extract and then wait around 3 months. As you can see, there is serious vertical and sinus bone defect. And there are so many things to be decided. And firstly, we have to decide graft first or place together and simultaneous approach, or we can choose the internal sinus graft or lateral sinus graft. And finally, we can choose after the implant installation, we can do submerge or we can do non-submerge. In this case, I choose the simultaneous approach and I choose internal sinus graft. And finally, I choose the non-submerged protocol. This is a brief introduction about these cases. First, after incision, I use the casket and then make the hole, and after fracture of the sinus, and I do the grafting. After that, I place the SS3 implant, means one-stage surgery. And after that, need the vertical augmentation, and I choose the non-submerged vertical augmentation. And after suturing, this is a panoramic view and CT view. And around 6 months later, I take impression and setting the final prosthesis. As you can see, the bone is regenerated very well. Now there is a main topic to be discussed today. And I want to discuss about the vertical augmentation, and secondly, the stage advantage of a simultaneous approach compared to the stage approaching. And then I want to explain the special incision design for the upper molar area. And so I want to introduce my special internal sinus graft technique. And next one is I want to explain the advantage of a transmucosal GBL. Then finally, I want to share my selection criteria for the graft material and the membrane. The first one is about the vertical augmentation. In this situation, we can place an implant just as with the sinus grafting, or we can do the vertical augmentation together with the sinus grafting. Think about the vertical augmentation necessary, and also we have to think about the ratio of a crown implant. Some papers said that the ratio of the crown implant is not significantly clinically important, no meaning. But some papers also said the ratio of crown implant, if it's increased, the load transfer to the structure of the alveolar bone is also increased. So it means the alveolar bone resorption can be increased, or prosthetic porcelain fracture and screw losing also can be increased. Now let's see this picture. The left side, we place, in this situation, the crown length is the same. And the right one, the crown ratio is about 1, and left one is 1.3. Because we place right side is place a more longer implant. But in this situation, there is no clinical meaning. But let's see the right picture. We place the same 10 mm implant, and the right side, the crown implant ratio is decreased because of the vertical augmentation. if you can do the vertical augmentation, so if you can reduce the crown implant ratio, is helpful, is meaning in the clinically. So if you meet this kind of defect, we can only do the sinus graft and with the long crown, or we can do the vertical augmentation with the sinus graft together, and we can decrease the restoration. It means that we can decrease the crown implant ratio. It's clinically meaning. My second topic is about think about the stage approach or simultaneous approach. It's around 10 years ago is my cases. When I meet this case, and firstly I decide to extraction both sides of molar area, and then 1 month later, I decide cannot place the implant. So I did the graft first, then laterally. At the time I choose the lateral sinus grafting and vertical augmentation. After grafting, I wait around 6 months, and I place the implant. But as you can see, because the vertical augmentation, I have to move the soft tissue to the coronally, and then there is not enough carotid gingiva at the buccal side. So before the final restoration, I did the FGG. And to solve these cases, it takes around 1 year and needs 3 times surgery intervention. Firstly, have to do the augmentation, and 6 months later, I did the implant installation and also did the FGG. At the time, I really satisfied about the final result. But I remember at the time, patient told me, "Thanks for your good job, but next time I really don't want implant surgery anymore." Even though maybe surgery is successful, patient satisfaction is not so much. At the time, I think patient satisfaction standard and then surgeon standard may be different. And also I experienced this case is maybe it's similar, need also vertical and sinus augmentation. But he is a medical doctor, and then his major is ENT. And he strongly told me he doesn't want a lateral sinus. So I also don't want to, and at the time, I choose the internal sinus grafting, and also he told me he doesn't want swelling and pain, and also I'm so busy. I don't want to so many times surgery. So I choose 1 time surgery. So I placed the SS3 implant, and then do the vertical augmentation simultaneously. So 1 time surgery, but everything is stable, and then I finish around 6 months later. And he also very satisfied about the result. This is a 5 years follow-up, and then as you can see, the bone is regenerated very well. And this case is compared to the last case, I choose the 1 time surgery, simultaneous internal sinus grafting and vertical transmucosal GBR. And after that, this kind of surgery has become my surgery philosophy. So I explain to, and then I advertisement like this way. My surgery concept is a 4L implant. Less implant, less surgery, and less pain, and less complication. Less implant means my major is perio, so I always try to save the tooth and then reduce the number of the implant. And always, patient doesn't want so many surgery intervention. So I try to reduce the surgery intervention and also reduce the surgery time. And I really don't like the pain swelling after the surgery. So try to reduce the patient discomfort after the surgery, and also try to reduce the implant complication. This is a survey in my clinic, and after surgery, I always ask to the patient, please write down your feeling after the surgery about the pain and the swelling. Number 1 score is no pain and no swelling. Number 5 is a serious pain and swelling. So average score is around 90% of the patient give me the positive answer. So I think this kind of invasive surgery is very helpful to the patient to decrease the pain and the swelling. So I already think about which surgeries would be more preferred by the patient. So I always choose, if I can get a primer stability, I always prefer the simultaneous approach. Next topic is about the incision design. So, as you know, normally we do the mid-crustal incision. Normally we do the incision at the mid area, but as you can see, I did the incision more buccal side. Why? Because I learned from the experience. I want to share another my past cases. These cases also need the sinus and vertical augmentation. So similarly, I do the internal sinus grafting, and after placed implant, I did the one-time simultaneous non-submerged vertical augmentation. After the vertical augmentation, as you know, always soft tissue is not enough. The buccal side is not so difficult. We just can do a simple religion, and then we can move the buccal side tissue at the coronally. The problem is the palatal area. As you know, if the palatal tissue is not enough, it's not so easy to solve it, because the palatal tissue, there is no mucosa. We cannot do the vertical augmentation. We cannot do the releasing incision. At the time, I choose the partial thickness flap and then make the palatal tissue coronally. We call this as palatal adipose flap. Maybe it's possible, but it's difficult. After surgery, palatal bleeding and patient discomfort can be happen. So, I always experience the palatal tissue is the problem. Palatal tissue is not enough. That's the problem. So after then, I changed the incision design to the more buccally, because I try to get more amount of palatal tissue. So corroding with flap at the palatal area is not so easy. So if it's possible, at the incision situation, try to get more palatal tissue. It's good for the soft tissue management. So this is the next topic. We always consider the sinus areas. If the bone is not enough, should I have to do the internal sinus or should I have to do the lateral sinus? As for me, recently my concept has changed. So when I decide the laterally or coronally, laterally or internally, my first decision making is the primary stability. If I can do the primary stability, means maybe remaining bone around 2 or 7 millimeter, most of cases can get a primary stability. So at the time, I usually choose the internal sinus with a casket. But sometimes, if the remaining bone is so less, maybe less than 1 millimeter, at the time I cannot get a primary stability. So in these cases, I open lateral approach and then graft first and press later. Maybe sometimes need a lateral approach because maybe during the internal sinus procedure, membrane can be teared. At the time we have to repair and we need the lateral approach. Or sometimes there is some foreign body in the sinus. When I have to remove it, we have to do the lateral approach. It's around 12 years ago. At the time, I also followed the normal standard. Left side, the remaining bone is around 3 or 4 millimeter. So I choose the lateral approach. And the right side is a remaining bone is around 7 millimeter. I did just a simple internal sinus grafting. After sitting, and I realized at the time, internal sinus has a limitation about the blood supply. Because after the internal sinus, just using the osteotomy, so blood supply can be only from the alveolar area. But lateral area, the graft material can be changed with the bone more easily because so many area can blood supply is happen. So at the time, I believe if there is not enough remaining bone, maybe less than 4 millimeter, lateral augmentation is necessary. But with time, my concept has been changed. Recently, my favorite science technique is a mostly internal sinus grafting using cascade with a gel-type bone injection. I will introduce what is the gel-type bone injection. So I think a key factor of the success of the internal sinus grafting is a wide elevation of the sinus membrane. That is most important. As you know, to elevate the sinus membrane widely, hydrolyte lifting is well introduced, but I prefer the gel bone injection. You know, using the hydraulic membrane lifter, we can elevate the sinus membrane widely. This is also a very good technique. But I want to introduce what is the gel bone injection. I used the allografting named shear fuse provided by the Osstem. This is a young lady. She's very afraid of the surgery because she visited another clinic and then she heard that need maybe more than 3 times surgery and need a black bone at the iliac bone area because there is only 1 millimeter bone. So she's afraid of surgery, so I persuade her, don't worry about the surgery. I will not do the incision and I will not take any bone from your body. So it takes around 10 minutes, it's very simple. So I choose the Fleming's surgery and after punch the soft tissue and using the cascade and then inject the gel bone. As you can see the CT, after the gel bone injection, the membrane elevated very widely. But only this gel bone injection, this bone can be resolved with time. So need the genograft to maintain the volume. So after gel bone injection, I added up the genograft into the sinus. After make the hole and then make the using the cascade, I injected a gel bone into the sinus slowly. But one whole area maybe need a 0.3 around 0.5 cc is necessary. After gel bone injection, added the more genografting and then I placed the TS3 implant. There is not so much bone, but we can get a stability using the under drilling. I will introduce later about what is under drilling. I can get a stability around 20 Newton, so I just connect the healing abutment instead of the submerge. So it's a very good surgery for the patient. Just one time and no incision. This is after the surgery, CT view, and as you can see, there is a 2 layer. One layer is elevated membrane by the gel bone. The other layer is elevated by the genografting. Around 6 months later, the bone is regenerated very well, and 5 years later, the bone stable, very stable. So, I think the effect of gel-type bone injection is it can make the sinus membrane very widely, like extended lateral sinus grafting. So it means it helpful to the bone supply. It means it helpful to the graft regeneration. So this is an image of the gel bone injection. I injected a gel bone very slowly and then elevated the membrane very widely. And after that, need the genograft. So this is a typical comparison of the normal particulate bone grafting and or gel bone injection with the particulate bone. So in the previous, only the particulate bone grafting cannot membrane elevate widely. But as you can see, after gel bone, the membrane elevate like this way, and after that, particulate bone grafting is like this way. So I think the advantage of gel bond injection compared to the hydrolifting, because gel bond has a viscosity. So this case is the same patient. After 0.3 cc injection, the membrane elevated around 60 millimeter, and then I injected one more, and the membrane elevated more. It means using the gel bond, we can control the amount of elevation. And this is a paper by Dr. Chang-joo. So if we use the hydraulic lifting system, so we want the dome-shaped lifting, but off-center dome shape is frequently happen. So I also experienced a similar situation. The left side, I used the hydraulic lifting, but the membrane elevated like a off-center dome shape, because the water maybe can be distally. But the gel bond is elevated the membrane, just the center area, like a center dome shape, because the gel bond has a viscosity. Let's go back to the main cases. After raise the flap, I make the hole using the casket. And after that, I inject the gel bond very slowly around 0.5 cc. After that, I take a CT, and then you can see the membrane elevated very widely. And after that, only the gel bond can be resolved with time. So I graft the genograft, mix with the PRP, and then maybe around 0.5 gram is I added up. Now after that, I place the SS3 implant. I get a primary stability around 20 Newton. So most of the doctor ask me, there's not so much bone. How can you get a stability? So it's not, I know it's not so easy, but with experience, you surely can get a stability even though there is a 1 or 2 millimeter remaining bone. So I recommend one thing is important is precise drilling. Recently, the one casket is developed. If you use the one casket, you can do the precise drilling. But I think a more important one is under drilling. So for the 5 diameter implant, we need 0.1 or 0.3 final drilling, but we have to decrease the final drilling sizes. Sometimes I choose the 6.6, 3.6, or 3.8. If we decrease the size of the final drilling, we can get us stability even though there is not so much bone. I will show you, this is another cases. There is the number 7 area, there's only around 1 millimeter bone remained. Can I get a stability? I will show you. I think maybe even though there's a 1 millimeter remained, bone quality is also important. If it's a soft bone, maybe cannot get a stability. But this case is well, we can decide this is a normal bone. So I choose the flammable surgery and make the hole, and then I place after the same procedure, I place a TS3 implant. And the second molar area, at the first time, I tried to place the 5 diameter implant, but the final insertion torque is around 12 Newton, so I change with the 6 diameter implant, and finally I get around 20 Newton. And so after that, I can connect to the healing abutment. This is final, and I show you the video clip. Using the punching and the limited soft tissue, and using the casket. And after make the hole, and then I inject a shear fuse slowly. After then, added up the genograft. and I place the TS3 implant and the second molar area. So I cannot get enough stability. I change it with a 6 diameter TS implant, and then finally I get around the 20 Newton insertion torque, and I connect the healing abutment. And as you can see, the bone is grafted very well. It's a very simple, very less invasive surgery, and it's good. I do believe this is really good for the patient. This is next topic. I want to introduce the advantage of a transmucosal GBR. Conventionally, when I do the vertical augmentation, I choose the submerged protocol. But the problem after the vertical augmentation, soft tissue always not enough. So needs a tangent-free, for the tangent-free primer closure, we have to do the vertical incision at both sides, medial and distal, and after that we have to do the releasing. But the problem of this procedure, move the soft tissue to coronally, and then also after surgery, patient swelling is severe. But sometimes, even though I try to do tangent-free primer closure, sometimes wound adhesions can be happen. So I want to say that again, the problem of submerged vertical augmentation, one thing is a post-operative pain and swelling, and then the possibility of adhesions may be increased, and then after that, keratinized tissue at the buccal side always not enough. Maybe it means sometimes maybe need the FGG is necessary. But if you choose the transmucosal vertical augmentation, I will call this TBA. So the advantage, soft tissue management is very easy. And it means after the surgery, patient pain and swelling is minimized, and then wound adhesions possibility is also decreased, and we can preserve keratinized tissue at the buccal side. So let's get back to the cases. Also, in these cases, I also choose the transmucosal vertical augmentation. So I place a SS3 implant. And it's my preference. I also, most of in my clinic, maybe around the 70%, I choose the TS3 implant. But sometimes I choose the SS3 implant. Mostly I prefer a single molar area. I choose the SS3 because structurally SS3 implant is very stable. So single molar area I prefer SS3 than TS3. But most of the case I prefer TS3. So after that I do the grafting and covered with the PRP. I didn't use any non-reachable membrane. I will explain later. And then because I connect the healing abutment, the soft tissue deficiency is not so much. So, and the palatal area at the incision situation, I preserve more palatal tissue. So palatal area, the palatal tissue is not enough. So I can cut the palatal tissue and then move to medial area. We call this a Parach technique. And the buccal side, so the soft tissue is a little bit not enough. So I did just a simple undermining, and then I can primer closure very easily. As you can see, the mucogingival junction is not goes up coronally. We can preserve mucogingival junction. So also the soft tissue management is very simple. So after the surgery, patient swelling and discomfort can be minimized. So submerged transmucosal GBR is already reported is very successful. And it's my standard and my suggestion about the transmucosal GBR. Firstly, if we want to do transmucosal GBR, insertion torque should be more than 20 Newton. And it's a very advantage, especially for the immediate implantation. Because when we do the immediate implantation, after extraction, and if we place the implant, the soft tissue always not enough. If you want to submerge, always a lot of soft tissue management is necessary. But we just connect helium abutment, it becomes very easy. So the advantage is primary closure and can preserve the mucogingival junction. And the biggest advantage, I think, after surgery, even though we did the GBR, patient swelling and complication, it can be minimized. My final topic, I want to introduce my standard of the selection of the graft material and the membrane. I think the purpose of the bone graft, there is two main purposes. One thing is a bone regeneration, the other thing is a bone maintaining. Bone regeneration means if there is not enough bone, so we cannot place the implant, we have to do the graft first. In this situation, the graft material has to be changed with the bone. So I will call this situation is a BR. And BM means it's most of our experience. After the implant placement, maybe sometimes implant can be exposed. At the time we have to do the grafting. This procedure, we call this simultaneous GBR. And at the time, the purpose of the graft material just to maintain the spaces. So I call this as BM. I will introduce more detail about the BM procedure. In this situation, after extraction, we cannot place the implant. So maybe needed some vertical augmentation. And so I decide graft first and then place later, maybe 6 months later. So this situation, the graft material has to be changed into new bone. So we can, after 6 months later, this bone change the new bone and then we can get a stability. So this situation, the purpose of graft material should be changed into the bone. So I call this situation as a BR. I will introduce some difficult cases. As you can see, there is a very severe bone defect upper molar and also right lower molar area. Right molar area, normally we cannot place the implant. Even if we wait more than 1 year, this kind of through and through bone defect cannot be regenerated. We have to do the graft first. I wait around 1 month, and after then, I decide the graft first. We call this a two-stage GBR. And after raise the flap, I mix it with the two graft material. One thing is a normal particulate allograft, and the other thing is a gel type allografting. If you mix it with the two type of graft material, this bone graft is become very stable. So I call this a SM bone because this bone itself can make spaces without any non-resorbable membrane. So I think this kind of SM bone, even do the vertical augmentation, normally I don't use any non-reachable membrane. So I graft using the SM bone and I cover with a long-lasting collagen membrane. Because in this situation, this kind of long-lasting collagen membrane helpful to the graft material regenerate well. And I do the primer closure. This is after panorama. I wait around 6 months. And this is a before and after picture. As you can see, the vertical bone defect is become solved. And then after razor flap, I place the implant. And I can get around 30 Newton of insertion torque. So even though there is no bone exposure and no fixture exposure, but I always do graft more using the genograft because also I run from the experience. In the past, I just finished. I didn't graft anymore, but I experienced this kind of graft material using the allograft can be resolved with time. So after this kind of experience, I always added up xenograft surrounding the allograft area because it can prevent allograft resorption and it can maintain the bone volume. This situation I can call this is a BM. And 6 months later, this is final restoration. So 1 year follow-up, and 2 years, and 4 years. The bone maintained very well. So I think if you use only allograft for two-stage GBR, I think there is a possibility for bone resorption with the time. So I think it's better to edit the xenografting at the time of implant placement. It can maintain the bone volume. And BM, kind of bone maintaining, there is a several situation. Normally at the time I prefer using the xenografting. The first one is cover the exposed implant area or maintain the bone thickness or to get an ideal ridge form. The first one is a very common situation. After implantation, maybe fixture can be exposed. At the time, we did the grafting. In this situation, the purpose of the graft material is just to maintain the spaces. And sometimes the anterior area, even though there is no bone exposure, so we need the bone grafting because to prevent the labial bone resorption. And in the molar area, this kind of situation, also this situation, there is no fixture exposure, but for the better contour, sometimes you have to do the bone grafting. All of this kind of bone graft material, the purpose is just to maintain the spaces, do not resorb. So I call this as a BM procedure. Let me say again, there is a main purpose, and one thing is a BR, the other is BM. BR, normally I use the allografting because in this situation, the graft material has to resorb and then change into new bone. So allografting is more preferred. And in the BR situation, the bone quality is important. But BM, normally I prefer the xenograft. It does not have to be resorbed. It just maintains the bone volume. So in this situation, bone quantity is more important. And now I think about the membrane. As you know, the critical membrane criteria is, we say like this way, biocompatibility, cell occlusive or space maintaining, and tissue integration, and clinical manageability. But sometimes I ask to my doctors, why do you use the membrane? Why do you use the membrane? I think it's the main reason. There is two main reasons. First one is for cell occlusive, and the second one is for the space making. But I want to add one more, role of the membrane, just to protect of the graft material during the first surgery. It means that sometimes during the grafting procedure, maybe bleeding and suction, and maybe so much graft material can be lost. But if you covered with the membrane, we can protect the graft material during the first surgery. So sometimes if we meet the non-contained defect, there always the graft result is not so good. Why? Because if we meet the non-contained defect, there are some problem. Firstly, in this kind of non-contained defect, cannot protect the blood clot, and if you do the graft material, can be displaced. Also, membrane also can be collapsed. So usually in this kind of, if you meet the non-contained defect, we recommend non-reachable membrane. But there is one problem. If you use the non-reachable membrane exposure can be happen. Also, always need the second surgery and difficult to manage. and maybe material cost maybe can be increased. So this kind of typical non-rigid membrane titanium mesh or titanium PTF membrane, maybe recently I seldom use it. But now we can use more simple non-rigid membrane. Like os builder, we can make a space very easily compared to the previous titanium mesh. Or, well, recently I prefer assemble. Assemble means this graft material itself can make the spaces. So, doesn't need any non-rigid membrane. So I will show you how to make assemble. It's very easy. So just mix it with the PRP. You can make a graft material more hard, so you can make the spaces without any non-rigid membrane. Or if you mix with the gel type bone, this bone also can use it without any non-rigid membrane. There is a very thin bone, so after the implantation, need the graft. But normally, if you use just a mixer with the saline, if we protect the spaces, we have to use the non-rigid membrane. That means that we need the second surgery again. But I don't like to do the second surgery again. I just use the SM bone, so it can make the spaces. And I just cover with the PRP. The role of PRP, protect the graft material during surgery. So as you can see, after the surgery, the CT view, the graft material space does not collapse without any non-rigid membrane. So in this case, there is a very simple canal-placed implant. I decide the two-stage GBR, graft using the allograft first. And this is mixed with the gel type bone with the particulate allografting. This procedure does not need any PRP. Just mix with the gel bone. This kind of gel bone can become very hard. And add it up and make the spaces. The buccal side also and parietal side. And this situation, even though after saline irrigation, this graft material does not go away, very stable. So I don't need any non-rigid membrane. But in these cases, I just cover with the collagen membrane, long-lasting collagen membrane, because in this case, I have to do, this bone has to be regenerated. I have to place 6 months later. So if I cover this collagen membrane, it's helpful to regenerate the bone. So let's go back to the cases. In this situation also, do the vertical augmentation without any non-rigid membrane. Just the xenograft mixed with the PRP. This is a SM bone. I don't use any non-rigid membrane. Just the cover with the PRP. So very simple management and suturing. So as you can see, the vertical area, the graft material does not collapse. Also, final result, the vertical area regenerated very well. This is a 2 years follow-up. As you can see, the bone is regenerated very well, also maintains space very well. This is a series of the CT. This is the final restoration. I want to summarize using the video clip these cases. So this is a buccal tilted incision for the keep the palatal tissue more. And raise the flap. You can see the vertical bone loss at the buccal side. Using the casket, I don't like the fracture the sinus using the casket into the drilling mode. I just drilling maybe 1 millimeter less than the final remaining bone. During the drilling, I don't make the fracture the sinus. After final drilling, sometimes I use the osteotomy to make the sinus fracture, or sometimes I change it into the slow motion of the RPM because I want to feel the sinus fracture moment. Now I can feel the sinus fracture because I changed the slow motion. And after then, I inject the gel bone into the sinus. Around 0.5 cc, and then added up genograft around also 0.5 cc. If you mix the PRP, it's very easy to grafting into the sinus. And then place the SS2, SS3 implant. Get around the 20 Newton insertion torque, and I connect the healing abutment. After then, I have to do body augmentation. This genograft mixed with the PLP, it becomes the SM bone. The buccal side and the palatal side, I did a vertical augmentation. And then cover with a PRF. This procedure has helpful to management of flap. During management flap, sometimes graft material can be lost, but if you cover the PRF, you can protect the graft material. So, because I choose the transmucosal vertical augmentation, the soft tissue not so insufficient, not so much insufficient. Just need a simple releasing technique. And the palatal area, there's enough palatal tissue, so I use the palette technique and can cover the major area. This is a very simple suture. Just to interrupt this suture is necessary. As you can see, the mucojugal junction can be preserved. And after surgery, patient's swelling is not so much. So now I want to introduce my hospital team. During Corona period, my hospital team worked very well, and so we can pass the Corona situation. Now I want to introduce my hospital coronavirus prevention system. I use this video clip on my webpage or also in the TV on the waiting room. Make the patient watching this TV. So during this kind of my hospital prevention protocol, so in my hospital, the hospital income and the number of medical surgery not so much decreased compared to last year. I think make the patient feel safe in your clinic. This is very important. I wish all the doctor in here stay safe. Thanks for your kind attention. Let's keep in touch with the Facebook. My ID says The Wise. Thank you for your attention.
Hi, Dr. Im. Thank you very much for your nice presentations.
My pleasure.
I believe it must help all viewers today and for the sinus lift surgery. What do you feel about this online presentation? Maybe this is versus the offline presentation.
It was great. It's a very good chance to meet all the doctors in the world without any special limitation. I do believe this kind of online conference become more trend, and then I think Osstem will step forward.
Yes. Yeah. Now we move to Q&A sessions about the sinus lift surgery. All right, we are going to the Q&A sessions, and maybe a lot of the questions may be in the website. And the first one is, in your case, I saw among the internal science cases, I saw you did the flemish surgery. What is your decision for such a situation, flemish sinus surgery?
Yeah. I call this is fish technique. It's named by me. Flemish internal sinus injection technique. Sometimes I prefer because it's a very minimal invasive to the patient. So I think this kind of fish technique needs those following. Firstly, you have make sure you can get a stability, maybe around the 20 Newton. And secondly, there is enough keratinoid tissue, especially buccal side. And if there is not enough keratinoid tissue, if you do the flemish surgery, there is no keratinoid tissue at all buccal side. Yes. That will be problem. And also, there is enough bone width, and then also there is no crestal bone any defect. If there is any crestal bone defect, we have to raise the flap. We have to do the grafting into the gingiva. So this kind of situations maybe is possible. I prefer the flemish internal sinus injection technique.
You mean in case of the abundant soft tissue and with the keratinized gingiva. And the next question is, you showed many cases, but I can see any decortication. So you did not perform the decortication during the bone graft?
Yeah. So many doctors ask me about why don't you do the decortification? So I think there's a pros and cons about the decortification. Some papers, maybe osteoclast acting like a cutting bone, so can make that bony tunnel, and then it can help to bone blood supply. So without any decortification. So also in my clinic experience, there is no big difference whether do the decortification or not. Maybe I think if I do the block bone, maybe decortification is very important. But like simultaneous GBL, like this kind of situation, I think decortification is not so necessary. You can make surgery more simple. That is the most important.
And the next question is, how did you manage the buccal flap during the vertical augmentation? Maybe you mean the incision more buccally, and how can you manage the buccal flap?
When I choose the submerged protocol after vertical augmentation, always the soft tissue is not enough. At the time, always have to do the two-side medial distal vertical incision, and after the releasing, sometimes cut back, so have to raise the flap coronally. But that always make the problem. Patient swelling, and then the less of the carotid gingiva after the surgery. So recently, I always try to do non-submerged GBR. So if I connected healing abutment, soft tissue deficiency is decreased. So it can helpful to very easily manage the flap. So at the time, just a simple undermining and releasing can solve the soft tissue problem. It's very easy, become easy. So I always try to connect the healing abutment and make it easier to soft tissue management. Yeah.
And another question is, you showed the gel foam using the sinus membrane elevation with the gel foam. So the gel bone. So is there any experience about the gel foam bone elevation of the sinus mucosa, the perforated and drop into the sinus cavity? And when such a case, and do you have any kind of the management or sometimes the prevention of such a case?
Yeah, always during internal sinus grafting, always maybe the membrane tearing always maybe happen. But I think during casket, sometimes also we can tear the sinus membrane. I think the first one, my protocol, if there is a 4 millimeter remaining bone, I just drilling until 3 millimeters. And then, so there is a 1 millimeter still remain. After then, I don't use the casket anymore. Because if I use the casket, we cannot feel the fracture moment of the sinus. At the time, I just using the osteotomy and try to fracture the sinus floor. And in this protocol, maybe we can decrease the membrane perforation. And then after then, I inject a gel bone, and I can feel if there is a perforation, the gel bone, some feeling, I can feel. I can feel, if there is any perforation. Or sometimes I take a CT, if the membrane is elevated very well or not. But if there is a perforation, at the time we have to open the sinus and then have to repair using the lateral technique.
Technique, I see. And some question is more precise explain about the gel bone.
There is some company provided a similar gel bone. I prefer the shear fuse provided the Osstem because there is a very good viscosity.
I see.
The other similar gel bone is too slowly. So it cannot elevate the gel membrane very well. So this is gel bone is allograft. The material is a DBM. But my effect just to make elevate the sinus. That's all. I don't expect any bone regeneration because this kind of gel bone can be resolved. Just elevate the membrane, and after then, I think the added of xenograft is very necessary for the long-term maintaining of the graft material.
You mean the viscosity of the gel bone is very important?
Yeah.
And you want the xenograft is for the space maintaining?
Yes, that's right.
Thank you very much. And I appreciate for joining us here, and hope we see you again on another Osstem meeting online session shortly. Thank you.
Thank you very much.
It's time to close this Osstem meeting online. We indeed appreciate for your watching with us. Osstem is committed to expanding its online lecture platform and diverse lecture contents for serve Osstem's sincerely clients in the world. Osstem meeting online, the next Osstem meeting online will be held on June 4th. Hope for you to watch and join us. We are facing many challenges with the spread of the COVID-19, but better days will return. Thank you very much for your joining us, Osstem meeting online. Thank you.
Osstem meeting online.